Welcome to Citrus. My name is David Lindeman. I direct our health initiative here at Citrus, and delighted to have you all here after the holidays. And greetings to our guests on our other campuses. We'll be broadcasting again to the other 3 campuses in Citrus. Please, I hope that you've all been able to get settled in. We're really in for a treat with our guest speaker, Dr. Molly Jo Coye. And I'm thrilled because, again, a good colleague and friend, as you'll hear, who's been instrumental in moving digital health forward and being a game changer in healthcare in general in the United States for the last few decades. So I'm now pleased to introduce our speaker, Dr. Coye, who is currently executive in residence at Avia, network of 24 large health delivery systems who are looking at innovations and delivery transformations in the healthcare sector. And she's been working with them to look at new digital health solutions. But more excitingly is Molly's tremendous track record in this space. For the previous 5 years, she was Chief Innovation Officer at UCLA Health and our colleagues down there, and was tremendously influential in bringing them into the digital space in a very large number of areas, helping them select new technologies, digital interventions, etc. And prior to that, it has held a distinguished career in a number of programs not across the United States, not only in government, but working with industry and working in the entrepreneurial space. As you'll hear, her current experience is wide. Her current number of positions that she sits on for boards, etc., is extensive. But she started her work with startups in 1995, serving with a startup here in Silicon Valley, and has only grown that and is now a tremendous resource for startups, for companies moving into the digital space, etc. She's currently not only on the Institute of Medicine, serves on the board of the Aetna company, but has in the past established some of the earliest work in the digital health space. And I, in particular, and colleagues like Steve DeMello, very proud to have worked with her when she established Health Technology Center here in the Bay Area, one of the first that really was responsible for moving a very large percentage of healthcare systems into the digital health space across the United States. And I particularly am pleased because she was a champion and led us as we set up our new Center on Tech and Aging. So without further ado, I'd like to turn this over to Molly Coye. Thank you.
Thank you very much, David, and good afternoon to everybody who's on this virtually as well. I'm pleased to get a chance to talk with you, and my only concern, as I said to David, was that this was going to come across as sounding somewhat negative as a talk, because my job is to talk about the barriers to adoption. And I think that we are making progress, and it's very helpful to understand what those barriers are in order to make progress. So there is a purpose to recounting all of these difficulties and the reasons why many things which to us as developers, entrepreneurs, investors, more recently as researchers following these developments, often seem more obvious than they do to the healthcare providers or even in some cases the patients. So let me go into it. I won't spend a long time on my background, but I do have the disclaimers and disclosures that we always offer now. I'll be talking on one slide about Avia, the company that I work with now, which is a networking group of health systems that band together in order to do pooled work on investigating digital solutions for healthcare challenges and speeding the process of adoption. I also am on the boards and have advisory roles as listed here, and just so you know, I have no financial relationships with any of the other products or services that will be described here, so I'll always be very direct with you if there's any financial relationship. So let me start out with something that's not in the healthcare world. Henry Ford, we know, brought tremendous innovation and change to the automobile industry, but it wasn't just the production line. It was also the car retailers, the dealerships that he pioneered around the country. So it was a distribution method and a way of reaching the consumer as well as a way of producing the goods. And if you keep that in mind, often what we do is develop products, and certainly in healthcare, the healthcare provider systems think in terms of the products and how they're producing them. They don't think of what really is the experience of the consumer. And they're not designing them for the consumer experience until relatively recently and very erratically across the landscape of the industry. But let's think of what the entrepreneurial response in the last 10 years is. If we look at the automobile industry, there are two major themes. One is Tesla, and the other we could say is Google, although certainly there are a million other entrants in the self-drive car arena. About 4 years ago, my brother was driving down a highway in California and saw a Google self-drive car for the first time. He's an early adopter like I am, we're all great fans of entrepreneurship. He got all excited about it. And it still is taking a fair amount of time, but what are these different themes? Think for a second. Tesla is the opposite of self-drive because you're making it the best driving experience. Elon Musk is working on making it the best driving experience, but it's a little bit like paving the cow path because it's basically reinforcing a relationship between you and the basic business model there. You are still the person driving it. In a self-drive car, in theory, eventually we will get to the point where you no longer are driving the car. And so it's a very different model. It says not that you want to have the best experience for driving, but that you really don't want to be driving at all. You just want to get from here to there. And there are a lot of patients who don't want the absolutely best experience of being in a hospital. They just want to stay healthy. And if you can help them do that at home without them even really thinking about it very much, they would prefer that. So think about that tension, because mostly and I'm sort of talking to you as though you all are engaged in this process of developing new technologies, digital solutions, or digitally enabled solutions, investing in them, selecting them. So essentially, the viewpoint I'm taking here is, why is this taking so long and why is this so hard? And part of it is that many of the inventions that we come up with that really would advance healthcare disrupt the traditional experience in business relationships. So the business models for innovations in care delivery today largely are intended to sell to health plans, employers, delivery systems, and to a certain extent directly to consumers and patients, although really that's pretty much secondary so far. The products are either point solutions, something that specifically helps with nurse rounding or with mental health access in a primary care setting, or they are platforms that would enable you to use multiple solutions and organize and provide access to that. The 4 key barriers that I'm going to talk about that are distributed pretty much across all of these business models are the reimbursement models, installed base and culture of healthcare, fragmentation of disruption, and regulation and scope of practice. So let me move into that. The kinds of trends that I'll be referring to, and there are many more, of course, is first of all a dramatic shift to providing care in the home and the community, recognizing that social determinants of health, self-management, and community resources are key enablers and issues to address in keeping patients healthy, and even if they do have chronic conditions, postponing or preventing the deterioration of the patient, the exacerbation of the condition, and the more expensive consequences and disabling consequences of those conditions. Value-based care, which you've probably been up to here hearing about, we'll talk a little bit about the reality of that. So those include ACOs, government established and now commercial in some cases, risk-based contracts in general, and bundled payments. Another trend is initially palliative care, but palliative care had initially been defined as the last 6 months of life, and in Medicare, you are prevented from accessing any kind of curative or therapeutic care once you enter into palliative care. And it came initially out of Kaiser, but it's now been spread nationally within Kaiser. Sutter has come up with a great model as well that's been well proven in research, which basically uses a system that identifies the patients very early, at least a year before, and often early in their career of the illness, if it's a guaranteed continuing deterioration or serious life-threatening illness, 24/7 access in the home, and after an initial physician visit, most of it is provided by nurses and social workers or community health workers. This is the single biggest innovation I have ever seen in healthcare. The second one that I'll talk about in a minute is tele-ICU in scale and scope. This is documented to reduce net costs of care in the last year of life by more than 35%. It is stunning. If this was a drug going to the FDA, it would be a blockbuster. And it's, to me, one of the best tests of why our health system is dysfunctional. Because this has been published research since the mid-2000s and replicated in a number of systems. And yet probably less than 5% of all patients in the country have access to this kind of service, even though the patient satisfaction is sky high with it. And finally, behavioral health, both the integration of behavioral health into primary care, as well as specialist and hospital-based, and particularly the grievous scarcity of providers of any type throughout the country. And so when I talk about in-home palliative care, that's just first on the list of opportunities that have been largely ignored. All of the usual means of distribution have been pursued. They're published. They're widely disseminated in professional meetings. The patient satisfaction is measured to be very high. The quality of care is equal or better. And yet these innovations have languished. The e-consult model, which basically uses a templated email exchange between primary care practitioners and specialists to avoid 40 to 60% of the need for patients to go in person for specialist referrals. San Francisco General Hospital pioneered it. Mayo Clinic independently and separately developed it to a very high level. The LA County Department of Health Services, which is the second largest Medicaid and underserved population provider in the country, instituted this in 2 years for 80% of all referrals and got that impact. It's really quite remarkable, and Kaiser Permanente has moved from their older model of just having specialists as floaters within the clinics to an actual e-consult system as well, which is quite elegant, the one that they've built. There was a real lack of software programs, platforms, and modules for this, but more recently, several entrants have emerged. And there would be a huge market for this if A, specialists weren't going to lose a lot of money, and B, our reimbursement system was capitated. And you'll hear this theme again and again. Tele-ICU, which many of you may be aware of, is really the grandfather of all these. It's in the literature since 2002 or 3. Increasingly good evidence, takes out about 20 to 30% of cost, length of stay, complications, mortality for ICU patients, And it was a startup in the early 2000s. It now has been acquired by Philips and is being re-engineered to go into the home and care for hospitals at home. So hospital at home is a big way to take a lot of your patients out of the hospital, have them never come to the hospital, and take care of them at home. And finally, grand rounds, where since we live in a world where most of our specialists were trained 20 years ago, 30 years ago, and get one cardiology in Maui conference a year, this is a way to make sure that patients get high quality diagnosis and treatment. It's sold to employers, and it's growing very, very rapidly. It's also offered to health systems as a way for them to actually be able to tell how qualified their specialists are, what gaps there are, what could be improved, and it's gone nowhere. So you begin to see the playing out of these negative incentives and barriers as we look at terrific opportunities. So the 4 barriers. The first one is the reimbursement model, and you will see the Obama administration had set the goal of 50% value-based care within a small number of years, and many health plans claim they're at 30%, 40% value-based care. You have to lift up the lid on this, because if you're trying to develop a technology that would be sold to either a health plan, a hospital that has ACOs, etc., think about really what this represents. Most of those contracts only represent 2 or 3% financial risk for the provider system. So you have a contract for 10 million or something like that. 2% of that is at risk, and often there's very limited downside risk. It's really just upside risk. And the result is that although it's called value-based care, it doesn't actually change the incentives for the provider system very much at all. So for those of you who are designing for this kind of a reimbursement system, for the idea that we're going to finally have incentives that reward for quality, experience, and lowered cost, don't drink the Kool-Aid too quickly. It would do that if it were true. And in very important pockets of the country and individual health systems, it's true. But this is limited. Second thing is, stop with the ROI. It's absolutely critical, but a minimal entrance to say that you're going to get ROI out of a product. ROI just means that within a year or two, you start saving more or making more than it costs you to mount the effort financially. None of the ROI calculations include the change management costs of really reorganizing a significant work process within a health system. So the real calculus by the COO, who runs the operations in the system, and the CFO, who is responsible for the finance, are that, yeah, okay, so we're not going to directly lose money on this in a year or two, but indirectly, the whole organization is pulled off course for this disruptive new, it might be all of the ED processes or some critical thing in the ICU, and it'll be years before you recover that kind of cost. So you need to be shifting to new kinds of metrics financially for this. Secondly, this is a little bit of a subtle point, but very important, that most major disruptive investments that will change a work process involve things like imaging systems or a big IT like EHR system or some kind of a device like a robotic surgery device. Those go through your capital expenditure decision process within a health system. Most digital solutions are so inexpensive. That's one of the wonderful things about them. But they're so inexpensive, they don't even hit the CapEx threshold. So therefore, the decision-making process about it is totally different. And most importantly, the investment money has to come out of current year operating expenditures, out of budgets that are already constituted. So you need to be going in talking with the health system very realistically about the financial analysis they're going to bring to this and what the timing is of their cycle of decision making in this regard in their budgets. And then finally, there really is no usual process for considering disruptive new approaches. There's no incoming committee or entity in many health systems for considering major disruptive changes in their system. A lot of the new innovation centers are working towards that, but they tend to focus just on point solutions that are pretty small pilots. So I just offer as an example Presbyterian Health System, 9-hospital integrated delivery network in New Mexico, which for several decades has had a managed care plan. They now have over 400,000 lives, and they are an avid consumer of innovation. Many of the things that I described, they are fully enmeshed in doing and doing it successfully. So this is not to say that there aren't pockets of real progress, but it's very important to distinguish that kind of approach from the petting zoo approach, which is, well, we're going to have 2 or 3 really exciting things that we'll pilot in one little unit and talk about a whole lot, but it won't actually change the way we provide care in a really big way. Second barrier is installed base and culture, and there are hard and soft installed bases. The IT and EHR system itself is mostly for documentation. It's not actually very helpful to the provider. I would say in Kaiser, for example, you can see where it's been optimized, and there are ways in which it is obviously tremendously helpful. But it can also be a real barrier, and the test case for that is how difficult it is to get decision support innovations integrated into most of the EHRs. Your staff configuration in the IT department and more broadly is built for the old systems. So try, 3 or 4 years ago, try and find a significant capability in the IT department of a hospital system, a healthcare system, that really understood mobile and was prepared to work on the assumption that most patients really wanted to communicate using mobile. It was very, very difficult. You also have, of course, a deep installed base in terms of physical facilities and the inherited culture of the professions. And then you have cultural challenges. And some of these I think we should be very respectful of. The first is first do no harm. I mean, there's a much higher threshold for changes in care processes than in many other industrial sectors because of the fact that this is people's lives that you're dealing with. They are used to 3 to 5 year clinical trials, not 3-month A/B testing as a way of figuring out what's going to work. So we need a lot more effort on actually driving to ground how we're going to demonstrate that something works. This is a huge area of need in research for digital solutions. And finally, that the culture in healthcare is very much mother may I, in sort of this like, you're not going to get in trouble if you don't make a decision or if you don't do something new and different. These are hierarchical systems, and they don't have the distributed opportunity for individual initiative and problem solving at various levels in the system that we're used to in other industrial sectors. An example of something that breaches much of this was the decision about 2 or 3 years ago by Sutter Health to adopt and then eventually invest in Augmetics, which uses Google Glass for remote scribing Oops, sorry, I thought I had my sound turned off. I was trying to remind myself so that I wouldn't go on too long, sorry. So Google, I don't know if any of you have seen Augmetics, but it's really quite exciting. I think personally that it's an early stage solution because it relies upon in-person scribes remotely, initially in India, now in the Caribbean, and a number of other areas where you can access physician labor inexpensively. But they're growing. Their limitation is supply, not demand. And it generally offers the physicians 2 hours or more less per day of documentation time in the EHR, and therefore they can see more patients. Therefore, the ROI is there within 6 months or less, 3 months in many cases. But it's a huge satisfier. So why is something getting adopted so fast? It's because it satisfies the physicians. And the problem with some of the other innovations that we're looking at is that it might be a better experience as a clinician, but the pay on a volume basis will go down. So, but this is a very interesting, and I've been following it at UCLA. We worked long and hard to try and get it introduced, and we only could get family medicine interested initially. So the third barrier is fragmentation of disruption, and this is a really tough issue to raise with all of you because many of you are individual entrepreneurs or with a small team and you're working on a point solution, something that has a narrow target, replaces a current work process or business model with something that's truly new and disruptive. But for example, there was just this article in New England Journal of Medicine where they looked at just the number of apps for breastfeeding, and there were well over 100 apps in existence, almost none of them particularly reflecting research, the research base for what is known or not known about that. Probably not a lot of them doing any damage. But if you are a health system, imagine doing the intake, assessment, decision-making, and implementation of something that's so narrowly construed, has such a wide field of competition, and is going to have a perhaps very helpful effect for the patient, but a very limited impact on your overall success as an organization. Even if you have an innovation center, whether they should spend time on figuring this out is really a question. Now, some health systems have gone into investing so that they get a staff of people who are in the business of filtering out these new, I don't mean just apps obviously, but new digital solutions as they come forward to figure out which ones they want to spend time on. And that's helpful. But if you contrast that with Salesforce as a platform that in its introduction affected marketing across all sectors, and think about what would be the equivalent. Think if you could move from an Epic, and again, I have no money in any of these companies, to an Athena, a cloud-based solution that is flexible and interfaces with all kinds of innovations. That is much more the kind of model in the future that we're going to need. And Epic itself is trying to go in that direction. We'll see if that is successful or not. So here I'm going to tell you a little bit about why I went to work for Avia. As David mentioned, for 10 years, I ran a nonprofit pooled research group, and we had about 25% of all the hospital capacity in the country as members. And Steve DeMello, who was the director before David, was actually the executive director of health tech of that organization. And Avia now is a for-profit company established to do the same thing. The average hospital takes about 23 months from seeing a digital need to scaling a solution. This is a tough area. There's a growing list of complex opportunities and no easy solution, and so many systems are joining networks. Avia is the largest one existing right now, has 25 plus health systems, and what we do is start with a health system strategy, find the digital opportunities that can be the best support for that, and the health systems work as a group, those of them interested, for example, in patient billing and transparency, will come together and take 60 innovative companies down to 2 or 3, and then do a Shark Tank kind of event for that. And then we support implementation. So there are some attempts at solutions to try to move this process forward and make it easier for health systems. And the final barrier that I wanted to mention is regulation and scope of practice. Regulation protects patients. It's very important to recognize that. I worked in government. I was commissioner of health for 2 states, New Jersey and California, which are pretty different states. But regulation per se is not necessarily bad, and it does protect, but it also creates rice bowls. It provides for physicians, for hospitals, for healthcare system executives, for everyone involved, an investment in the current structure that's consolidated in the regulations. So disruption that we might produce that lowers the cost of care, increases patient access, improves patient experience, often breaks these rice bowls. The professional scope of practice, a particular field of regulation, often makes it very difficult to innovate in the best use of human potential. And let me just give a brief example. In chronic disease, which is responsible for about 80% of all healthcare expenditures, and the majority of health problems that people have in the final decades of their life, chronic disease management is all about behavior change. To start with, take your meds, eat the right things, maybe get exercise. That may or may not be realistic, but it's basically about behavior change. Seeing a physician once every 3 months, 6 months doesn't cut it. There are 3 decades, 4 decades of research showing that a community health worker from your community is much more effective in frequent contact with you and getting you to change your behavior. Now we have AI nurse coaches that can do that for pre-diabetics. It's actually been shown in research. This is the company that I'm talking about is Lark, and they've got CMS approval for reimbursement, and they're expanding into a whole other sets of conditions. This kind of thing is radically, revolutionarily different in our approach to managing care. So the regulation of digital health is improving. It's being clarified now. I think actually FDA in the last 6 months had come out with some very positive policies in this area. And particularly we see telemedicine and telehealth emerging from a long period of constraints with very positive hope. And consumer convenience, trusted preference may drive changes in this area. So I'll end with the case of the Veterans Administration, which was exempt from the state regulation of telemedicine. They began their program in 2002, and from that time till now, almost 1 million vets have received teleservices, with decreases in ED, hospital utilization that averaged 23 to 56% for the populations using these services, depending on the condition. 1/3 of their population served as rural, and they have a high proportion of low socioeconomic status, meaning that all our ideas that this is for wealthy populations or middle-class populations are not true. They serve more than 30 diagnoses, and the strongest results they get, in the percentages in the 50s, are for depression and PTSD. So we are, I think, on the cusp of the point, because of cost pressures, where we will see more and more opportunities for providers and patients to respond to improved offerings, the opportunity for improved offerings for patients and for clinicians who are willing to reorganize their way of working and the payment models under which they will work. But the wheels grind slowly, and Churchill, who said Americans will do the right thing only after they've tried everything else, may well be right. So let me end there. Thank you very much for your attention, and I'm glad, David, to have a conversation or answer any comments. Yeah.
Just one word and we'll turn it over to you, the audience. Thank you, Molly. It was a wonderful overview from a macro perspective. Key challenges we have in the digital health space, but also how complex our health system is, particularly those of us who are looking at individual products, but also clinicians who are looking at innovative ways to serve populations, much less as we look at large systems change. So thank you for providing that wonderful overview. So we'll now have time for questions. We have mics in the audience, so please get a mic. I believe we have a question there, and we'll do a series of questions until the hour's up.
I guess I'm first. So related to, you said there's no usual process to kind of get this started, and I know there have been systems hiring innovation officers, maybe that's what they're called, or but I think, I guess my question is really sort of how to move that into the culture and maybe broader buy-in in the system, because you need the financial folks, but the people impacted by the change in scope and their change in workplace habits, and sort of maybe also tied a little bit into the folks who are working on value-based care and the quality improvements. So I guess it really takes a lot of stakeholders.
Yeah. Well, and this is one of the things as an innovation officer, one of the problems that I faced is that if you're just an officer with a couple of staff people, your ability as a sort of cheerleader in the organization is somewhat limited. And what you really need is to get all those other stakeholders involved and to not reinvent the wheel. And that's why after my nonprofit, I went to work with Avia, because we have, like, what kind of legal contracting do you want to do? You don't want to take a year and a half to redline a contract for a $50,000 pilot, you know, that kind of thing. So how do you go through compliance, IT, quality, et cetera? How do you get all the stakeholders involved and move things forward more rapidly so that you can fish or cut bait? And then secondly, how do you scale? The world is full of successful pilots that never went anywhere. That's the death trap. It's sort of like the valley of death in the hype cycle. But for this, it's really never scaling. And so the key thing is scaling. And for that, you need what I was talking about, the CFO and the COO to be bought in the beginning. We want, if it's successful in pilot, we want this thing. We're going to put aside the budget and the staff and the time to make sure this scales across the enterprise.
I have a question about reimbursements. I understand that a lot of digital health technology is not reimbursable by insurers right now. What is your organization or other tech companies doing on a policy level to change that?
Yeah. Well, the most positive thing is any form of risk-based reimbursement. And so ultimately, capitation, I mean, capitation is sort of like, it's a million forms of it. Capitation in a setting where you have alignment of the health plan, the providers, and if possible, the patients, is the best. If you have the plan capitated and not the providers, you don't get the full impact of it. So you need some forms of incentivization that align everybody. So we have, you know, the industry. I was on the board of the American Telemedicine Association for quite a while. I also work with private equity and venture as an advisor for 3 decades now. And they're a very important presence in Washington through American Telemedicine Association, AdvaMed, and in front of the FDA and CMS. FDA, in order to make sure that the regulatory framework actually tallies with and doesn't prevent the best kinds of innovations, and with CMS to try to not just get approval of each individual device or technology, because that is a mare's nest. It's just, there's no way that's going to pay off as an approach. What you want are bundled payments, ACOs, any kind of movement. And MACRA is actually, I think, even these things are always like lumbering dinosaurs, sort of, but MACRA is actually going to move physicians slowly towards more advanced payment forms. So that's why I'm optimistic. Otherwise, I'd listen to my own talk and go jump out in a lake. But I do think that the trend is long term, but it's in the right direction. The arc of history, I guess.
Thank you. My question is, thank you for pointing out Tesla versus Google, because in medicine, a lot of latest technology, artificial intelligence, they all try to shoot like a Google. Hey, I don't want to say get rid of doctors, but they want to just be there one stop. Now Tesla's model with physician or patients in the artificial intelligence system, it's kind of artificial intelligence assisted system. Do you think this is going to be an interim step for FDA to approve before they approve a standalone system?
Well, there's a very interesting article. I'm sorry I don't have the citation here. I'll try and find it and give it to David, and he could distribute it. But there's a very interesting article that tabulated what we know about computer-assisted decision-making, and including some AI. And I think they went through 6 or 7 different cases, and in all of them, the computer/AI, because I can't remember how many were just computer-assisted versus AI, were as good or better than the physicians. But if you did the two together, you often got at least a marginal improvement. So say you were just as a prototype, if the physician got it 75% right and the computer got it 85% right, you would get like an 89% right with the two of them. So the question now for AI will be, which cases need to go to the physicians in addition? Because probably it isn't all of them. So we're going to get so much smarter about this. There will be certain things, and they'll probably change, and new understanding of conditions will lead to a new role for physicians for a while, and then eventually AI will learn enough. So it's an iterative process. I don't think it should be fixed, which is why I am sort of afraid of a regulatory framework for this. At least one that locks in professional roles, because we're going to get very smart a lot faster than we did in the past. And it's important to not assume that the results we get today are going to be those a year from now. So.
Thank you very much for really excellent talk. I wonder if what you're presenting is underestimating the extent of the disruption that technology is going to have on health. Most of the models you're talking about still assume hospitals as the place you go when you're sick, doctors as the decision maker that hold the repository of everything we know, medical, et cetera. And I think that's going to go away. I think that we're going to reach a point where most of the information is not in the heads of doctors, but on the internet, and we're going to actually learn how to make it more available. In pediatrics, almost no kids now are in hospitals. They're better taken care of at home for a myriad of reasons, and I think the same is likely to happen with adults. So I think what you're describing is exactly accurate. I think it's the tip of the iceberg, and I think the biggest barrier is that hospitals are not going to disappear, but are going to be radically different. The role of doctors is going to be radically different, and doctors and hospitals and all the other people with a vested interest in the status quo don't necessarily want to see that happen.
Well, I hate to tell you, but actually you're singing my song. If we went back to the mid-2000s when Steve DeMello was the director of the nonprofit I had, we predicted that the hospital of the future would be no more than an acute trauma center for unavoidable trauma, some really expensive big imaging, although we didn't anticipate how much independent imaging centers are probably going to replace that, and possibly a limited ICU capacity, and a little bit of other types of emergency, although most of the other non-trauma emergency is now being dealt with in non-hospital-based emergency centers, which are working out very well. And I'd encourage you to go back in the slides, because if you put together hospital at home, which takes a lot of those patients out of the hospital and will take more, community health workers providing care in the home, rather than having people go to physicians for chronic care. And then you also put in the social worker and nurse model for in-home palliative. The 35% savings was taking people out of the hospital and the clinic and caring for them in the home. So the origins of what you're talking about are there. We have just been dragging our heels.
Thank you very much. Our startup is building a device that tracks a person's dietary and metabolic health at home by analyzing biomarkers in their urine. It's prevention of diabetes, CVD, hypertension. Obviously, the incentive for insurers and people who are paying insurance premiums is quite high, but this potentially reduces treatment costs. So what would be the incentive for healthcare providers?
Yeah, well, this is why I think that it's actually a pretty bad system that we have right now, that health systems individually have to make the decision about so many individual point solutions like that, because it isn't whether that will save money. And even if you gave them a capitated rate, and it's a relatively small, like couple hospital system or a medical group with maybe 600 or 700 physicians or something, they don't have the bandwidth and resources to figure out if that's really something they ought to be doing. And if they could do that, then they're ignoring 7 other things that could be really helpful as well. So it's just a broken process for that decision making. And one alternative is have it all be government regulation. I'm not a great proponent about that, because I tend to think that that will wind up as more of a barrier than a help. The alternative is to have the aggregation of the clinical provider capacity into networks like Avia or other ones. Premier does that. A number of other organizations do things somewhat similar. Because we need to speed the process of decision making, and it's less, as long as it covers its cost, there will be a lot of room for things that just meet ROI if it can be bundled together. If you had, every 6 months or every year, a process where you said, okay, clinical innovations that are lab-based, how many of those are we going to do? Here we're going to go through it all, and here are the 10 we'll serve up this year. You might be the loser in that process, but it's going to net get things moving forward much faster.
Just one more quick question, and we'll have time afterwards.
So, apropos your comment about having people treated at home, I live alone, and to give a trivial example, at one point I had a small tumor removed from my back, and they bandaged it, and they said, change this bandage once a day for 10 days. And I said, I can't possibly reach this. Now, it happens at the time I was still working for the university here, and I went into the medical clinic, and they changed the bandage for me once a day for a week or so, till the weekend or something like that. But the point is that there are a great many adults, even some children, but certainly adults, that are living alone and there's no one to provide nursing care at home. So if you're not ambulatory and you can't provide this care by yourself, it's not a feasible alternative.
So, David, did you pay for this question? This is a question about aging and technology, although it is pediatrics and everything else, as you point out. And the answer is sort of, well, what about Uber? Uber is providing transportation to clinics now, but they're also providing transportation for community health workers to come out to your home. You don't need a nurse to come to your home. All you needed was a friend to change your bandage. And so in the future, a capitated system would be smart to have a standby army of community health workers to go into the home. Say you were a little bit addled, which you're clearly not if you're coming to this talk, But say you were a little bit addled, you might need a community health worker to come take a picture of an infection every day to make sure that it was actually getting better. So there's all kinds of things that can be done in the home at less expense than having them come, because every time somebody winds up in the doctor's office or the ED, there are ancillary tests, there are, sort of zebra findings that have to be worked up. The cost is way over the individual cost of that visit. So you're totally right, and this is the area that we all should, do very well finding solutions for. It's easy. Thank you.
Well, on that note, I'd like you to join me in thanking Molly for not only a outstanding but provocative talk and very important issues here, but also we always want to recognize you as a leader in technology, particularly in alignment with our wonderful women in tech. Molly has been a force in this space for years, and we thank you for sharing your insights with us.
Thank you.